Hey everybody, welcome back to the ECG channel. My name is Reed, and today we're going to be going over a common, ECG finding that can describe a syndrome called Brugada syndrome. If you want to follow along with these ECGs, feel free to download them. They are linked in the description below, and you can make your own notes and save these for later. So what is Brugada syndrome? Brugada syndrome is a genetic syndrome. And this genetic syndrome is most notably associated with a genetic defect in one of the genes that encodes for this SCN5A protein. This is a sodium channel. This is responsible for voltage-gated sodium channels specific to the cardiac myocyte. And if you remember, that sodium is responsible for depolarization of the ventricles. And so there's actually, some hypothesis of why this causes an issue. Some say with depolarization, some say it actually causes an issue with some of the repolarization abnormalities. And we see evidence of changes within kind of both aspects on the ECG. There are some other proteins that are also implicated that are a little bit more rare. And so what is the problem with this sodium channel, or some people call it a sodium channelopathy, right? Is that it can predispose these people to sudden cardiac death, specifically caused by ventricular tachyarrhythmias. And so it has some ECG features that I think are interesting and that are useful for you when you're evaluating a patient, say, that has a family history of sudden cardiac death or a personal history of syncope of some sort, right? Younger people come in with cardiac arrest, right? You want to look at their ECG for this feature. And so we look generally in Brugada syndrome in leads V1, V2, and V3. So we're going to be focusing our eyes on V1, V2, and V3. We see here just generally we have a narrow complex rhythm with P waves that conduct to QRS. So this is a sinus rhythm here. So let's talk about the findings in Brugada syndrome. There's often kind of these different criteria for Brugada syndrome. There's some people that there's type 1, 2, and 3. You'll see that often cited. At the end of the day, Brugada is one diagnosis, but there are different types of Brugada findings on ECG. So these really describe what you see on an ECG. So let's talk about what we see. So what we'll notice here is that if we come up to V1, V2, and V3, so we're going to zoom in here on these leads. And so Brugada syndrome, there are a couple findings, and this is really characteristic here of type 1. So the first finding is that we will have in either V1, V2, or V3, ST elevation greater than 2 millimeters. Okay, so we have ST segment elevation greater than 2 millimeters. And a couple of things about that ST segment elevation is that it will be coved ST segment elevation, which I will explain to you in a little bit. And there will also be a inverted T wave associated with that coved ST segment elevation. And usually the ST segment itself will be down sloped. Okay? So those are kind of, to start, some initial findings that you'll see in this type 1. We'll say this is our type 1 Brugada findings. And so let's take a look here at this ECG. We'll look up here in V1. And so what you'll notice here is that here is our baseline. I'll do it in a different color so that we can see it better. Here's our baseline. And then notice our ST segment kind of is elevated by at least 2 millimeters, right? You can see the difference in the amplitude there. It's greater than 2 millimeters. You can see that we have downsloping ST segment and an inverted T wave. So this is already concerning for Brugada. You can also see that here in V2, right? Here is our baseline. We have even more marked ST segment elevation greater than 2 millimeters. We've got our downsloping ST segment with our inverted T wave. Now, a couple of things about Brugada that you will find is that one, we need to determine, this is, can be easily mistaken with a right bundle branch block, right? We know that right bundle branch blocks have like an R prime. Right bundle branch blocks usually have an R prime. The difference is that a right bundle branch block has a much sharper deflection, right? So right bundle branch blocks are a lot more sharp in their deflections. And so to help discern this finding from a right bundle branch block, there's also another ECG feature that we can utilize, and it's called the beta angle. Okay. Now the beta angle is essentially a measurement that's going to allow for us to determine how sharp is this ST elevation that we're seeing, this deflection. And so we know in Brugada, it is not as sharp, right? If you look here, notice that transition is very kind of flat transition, right? It's not a sharp up and down deflection. So what you can actually do is to calculate the beta angle, we'll do it here in lead V2. The beta angle is calculated by one, we draw a line through this upstroke of the QRS, okay? We draw a straight line then through the initial angle created by the ST segment, like that, okay? So this angle is the beta angle, right? That's the beta angle, is this angle right here, okay? But what you can do with the beta angle is that you can actually do a calculation. So what I like to do is I take from this J point, that's the J point, from the J point, I will measure 5 millimeters inferiorly from there, right? So we have 1, 2, 3, 4, 5 millimeters. So here's our 5 millimeters. And along that line, we're going to create a triangle. So we're going to create a triangle just like so. So that's our triangle that we created, right? That's our triangle. And so what you can calculate is the length of the base of the triangle. So if the base of the triangle is greater than or equal to 4 millimeters, that is criteria that gives more data to having likelihood of a Brugada syndrome, okay? So the beta angle, the wider the beta angle, the higher the number is that is going to be associated with the base, the length of this base, right? Imagine if we drew kind of this another example of my beta angle. If my beta angle was a lot wider, right? Notice this angle here is a lot wider, then the base calculation is going to be larger, right? So the larger the base created, the more likely you are to have Brugada. And 4 millimeters seems to be a decent cutoff. So let's talk about the findings in Brugada, right? V1, V2, and V3, we just need to have this in one of these three to have the most diagnostic criteria, which is type 1. So we're going to have ST segment elevation greater than 2 millimeters. This segment elevation is going to be coved. There will be downsloping of the ST segment that is followed by an inverted T wave. Okay, and we can best see that here in V2, we will say probably has the best example of that, right? V1 also has a good example of that. Let's take another look at another ECG that has Brugada. You'll instantly notice here, we come in, we've got a sinus rhythm. We're going to focus in on V1, V2, and V3 here just for education's sake. And if we look here at V1, my baseline my baseline is about there. My J point elevated just to over 2 millimeters. Okay. And then if I do my beta angle, right? There's my baseline. This is the angle created, my beta angle. I measure 5 millimeters down from there. 1, 2, 3, 4, 5. I draw a line to create my triangle, and I notice that the length of the base, which I'll draw in red, the length of the base is greater than 4 millimeters. So that gives me more data to Brugada. And we also have what? An inverted T wave. Okay. Something else that you'll notice in Brugada about the ST segments, this is just more kind of data about Brugada. The ST segment will not flatten. So the ST segments will oftentimes not remain flat. And so you see that here, if I look at this lead, V1, and I look at this beat, notice we don't have a moment where the ST becomes isoelectric, right? It's always either going down in some way, right? It doesn't ever become completely flat for any extended period of time. We see that here in V2, right, where you have this ST segment elevation. You can see it descending gradually, and then we have elevation, but notice it never flattens out for really a considerable amount of time. So oftentimes in Brugada, you'll see the ST segment does not go flat, right? And this right here is another example of type 1 Brugada syndrome, okay? You often hear about this saddleback morphology, right? That saddleback morphology is commonly seen in a type 2 presentation for Brugada syndrome. Type 2 is though you only have this saddleback, right? And here we have the typical type 1. Here's just a good example of saddleback, right? And so if you only have saddleback and you don't have some of the previously mentioned criteria that we have up here for the type 1 Brugada, if you have the saddleback, that's just a type 2, okay? And so that is pseudo-diagnostic for Brugada in the sense that if you have type 2, you're going to do provocative testing. Now, what is provocative testing? What does that mean? Well, you see something and you're like, well, I think this could be Brugada. You know, Brugada has to kind of unmask itself, right? And so what you can do, we know that Brugada is commonly due to this sodium channel, SCN5A. So we know that this is a sodium channel problem where it's decrease channel function, right? So what if, to help unmask it, we give a medication like procainamide? Okay, procainamide, what is its mechanism of action? It's a class 1 antiarrhythmic. It's a sodium channel blocker. So ideally, you could, if you have like a type 2, you could give procainamide and then take another ECG and see, so then you repeat ECG, and what do? You evaluate for a type 1 pattern, right? So that's a really good example of how you could use procainamide for provocative testing if you have a type 2, which is when you just have this isolated saddleback pattern where you've got ST segment elevation, downsloping but coved ST segment elevation, right? Notice the T wave is no longer inverted in this type 2, okay? So that's type 2. Type 1 and type 2 are really the only ones I think you really need to know and focus on. At the end of the day, these are all just kind of on this spectrum of Brugada type findings. And so you're probably all wondering, well, why is it just focusing on leads V1, V2, and V3? Well, remember that these leads kind of point towards the right ventricle. And there is some data, hypotheses that talk about maybe there is a, the most susceptible region of the myocardium is the right ventricle outflow tract, right? That maybe is what actually shows this the most on ECG, which is why we have findings of these things on V1, V2, V3. So let's look at one more together just so we can get another rep in, right? And then I'll leave the last one for you to look at. So here we've got a sinus rhythm, right? We've got P waves that conduct into my QRS complexes. And then I'm, curious, this person's got a family history maybe, and sudden cardiac death of, their parents have been in their 40s and 50s, young. And so we look up here in V1, V2, and V3. In V1, I can see a little bit of ST segment elevation, but it's not quite 2 millimeters. I do see, though, that my ST segment is downsloping with an inverted T wave, so I'm like, this is interesting. Let's look at V2 to see if there's anything more. And yes, look what we have. We've got, here's our baseline. Here's our ST segment elevation that is greater than 2 millimeters, right? We've got a downsloping ST segment that doesn't really flatten out, and then we have an inverted T wave, right? There's my inverted T wave. So we've got some pretty good data here that this is Brugada, but we want to make sure that our beta angle is consistent with Brugada. So I zoom in, I create my line through, and then I create my line through here. And then I measure 5 millimeters. So we've got about 1, 2, 3, 4, maybe 5 is right there. I draw the base of my triangle. And so the length of the base, which is right there, is greater than 4 millimeters. So more data for Brugada. So you have all these findings. What are you going to do? Well, first, you can do genetic testing, right? Determine, is there a genetic defect, loss of function to any of these channels that are associated. And 2, they are going to get an implanted cardioverter defibrillator, right? ICD is the standard of care for these people. They need to be able to shock if they go into a lethal rhythm, right? These people have a higher likelihood of going into a ventricular tachyarrhythmia. So I hope this helps you understand the morphology and some of the clinical features that are associated with Brugada, right? In order to diagnose somebody with a Brugada, it's very multifactorial. They need to have a family history. There needs to be, potentially a genetic identifying component here, family history of sudden cardiac death, and all of these features also are going to point you towards that direction. Okay, so if you have any questions about Brugada and the morphology, definitely put those down into the comments. And thank you so much for joining the channel, and I hope you have a great rest of your day. See you at the next ECG video. Take care.